Hey everyone, and welcome. Today we're going to dive into the really complex and honestly often misunderstood world of personality disorders. We're going to break down what they are, how they're grouped together, and what support actually looks like, all by digging into the clinical source material.
So this is the big question, right? This is what we're here to figure out. We all have our little habits and unique ways of being. But when did those patterns become something more? When does a quirk cross that invisible line into a clinical diagnosis that really, truly impacts someone's life? Well, let's find out.
All right, so first things first, we need to build a solid foundation here. We need to establish what clinicians are actually talking about when they use the term personality disorder. Because it's not just about being different or eccentric. It's about a very specific, disruptive pattern of impairment. And here it is, the core clinical definition. Now, the keywords to lock onto here are pattern, pathological, and impairment. This isn't about having a bad mood for a day or even a tough week. We're talking about a long-term, deeply ingrained pattern that seriously messes with how a person sees themselves, how they navigate their own life, and crucially, how they relate to other people. So what does that pattern actually look like in day-to-day life? Well, we're talking about things like having really inflexible or unhelpful ways of responding to stress. We're talking about an inability to really truly connect with others on an emotional level, and even a tendency to stir up conflict in relationships. The most important takeaway here is that it's the rigid, persistent nature of these traits that defines the disorder. Okay, so to make sense of all this complexity, clinicians group the 10 recognized personality disorders into 3 separate buckets, or clusters. You should think of this as our roadmap for the rest of this explainer. It's the framework that helps us organize these conditions based on their biggest shared traits. And here you can see that roadmap laid out really clearly. So you've got cluster A, which is all about odd or eccentric behaviors. Then there's cluster B, which covers traits that are dramatic, emotional, or erratic. And finally, cluster C, which is centered on anxious and fearful behaviors. We're going to walk through each one, so try to keep this little map in your head as we go. Okay, let's dive into cluster A. The common thread that ties all the disorders in this group together is the sense of being, well, different. We're talking socially awkward, withdrawn, in ways that other people might find pretty strange or eccentric. So let's do a quick snapshot of the 3 disorders in this cluster. First up, you have paranoid personality disorder. This involves a deep, pervasive distrust and suspicion that pretty much everyone is out to get you. Then there's schizoid personality disorder, which is really characterized by emotional detachment and a profound lack of interest in relationships. And finally, we have schizotypal personality disorder, which is marked by odd beliefs, maybe some magical thinking and eccentricities that make social connection really, really tough. All right, on to cluster B. Now, this group is probably the one you've heard the most about in movies or on TV. The core features here are things like instability in emotions, a lot of impulsivity, and behaviors that often come across as dramatic, erratic, and pretty unpredictable. But before we even get into the specific disorders, we have to talk about a very particular defense mechanism that you see a lot here, especially with borderline personality disorder. It's a concept called splitting, and honestly, it's fundamental to understanding the way relationships work or don't work in this cluster. So, what is splitting? Well, you can think of it as a pattern of black and white thinking. A person who's using this defense mechanism literally can't hold 2 conflicting ideas in their head at the same time. This means that people, or situations, or even themselves are either 100% perfect, amazing, and wonderful, or they're completely terrible, evil, and worthless. There's just no middle ground, no gray area. This quote, taken right from the source material, is a perfect real-world example of splitting in action. See how it works? One person is idealized, they're the best. The other person is immediately devalued, they're absolutely terrible. And these extreme swings from one pole to the other can happen incredibly fast, which is what creates such intense and unstable relationships. So, with that idea of splitting in our minds, let's look at the disorders. First, antisocial personality disorder, which is marked by a total disregard for other people's rights and a real lack of empathy. Then there's borderline, which we've touched on, involving that intense emotional instability and a deep fear of abandonment. Then we have histrionic, which is characterized by this constant, overwhelming need to be the center of attention. And finally, narcissistic, which is defined by a sense of grandiosity and an insatiable need for admiration from others. And that brings us to our final group, cluster C. The engine driving everything here is anxiety. The behaviors associated with these disorders are all rooted in an intense sense of fear, inadequacy, and a need to be in control.
Now, this slide highlights a really important distinction that can be confusing. Both avoidant and schizoid personalities can lead to someone being very socially isolated, but their inner motivations are polar opposites. Someone with avoidant personality disorder desperately wants to connect with people, but they're just paralyzed by an extreme fear of being rejected. On the other hand, someone with schizoid personality disorder simply has little to no interest in the first place. Understanding that internal driver is absolutely key to the diagnosis.
So, to round out cluster C, we have avoidant, which we just covered. Then there's dependent personality disorder, which is defined by a deep-seated need to be taken care of, and that often leads to very submissive behavior. And finally, obsessive-compulsive personality disorder. This is all about a preoccupation with order, perfection, and control, so much so that it actually gets in the way of getting things done. It's not the same as OCD. A key difference is that people with OCPD tend to think their way is the correct way, while people with OCD are often very distressed by their own obsessive thoughts. Of course, understanding the diagnosis is just the first step. The next logical question is, so what can be done? This final section is all about what care and support look like. We're going to focus on the therapeutic principles that can help people manage their symptoms and build more stable, fulfilling lives. You know, the overall approach to care can really be boiled down to these three crucial steps. First, building a relationship that is both firm and supportive is absolutely essential, especially when trust is a major issue. Second, consistency is everything. Having clear, predictable boundaries and responses helps create a safe container for therapy. And third, very specific types of psychotherapy are used to target the core issues of each disorder. One of the most effective treatments out there, especially for borderline personality disorder, is something called dialectical behavior therapy, or DBT. The dialectical part is the genius of it. It works by balancing two seemingly opposite ideas, the total acceptance of the person exactly as they are right now, and a simultaneous focus on gradual change by teaching practical skills to manage emotions, handle distress, and improve relationships. This point is so important that it's worth saying again. For disorders where manipulative behaviors can be a feature, like in borderline and antisocial personality disorders, setting firm limits isn't about being punitive or mean. It's actually a core part of the therapy itself. It provides the structure and the safety that are absolutely necessary for any real growth to happen. So we'll end with this question to think about. Now that we have a better grasp of these underlying patterns, the inflexibility, the deep-seated fear, the emotional instability, how can this clinical framework help us move past judgment? How can it help us see the profound human struggle behind these difficult behaviors and maybe practice a more effective, more informed kind of empathy for the people living with these conditions?